So next we're talking with Elaine Fontaine, who's Director of Data Quality and Analytics at the Rhode Island Quality Institute and Current Care. Thank you very much for being with us today.
Thanks for having me.
We all know, Elaine, that we need new financial models to make healthcare work the way we'd like it to work. The students are quite familiar with that from earlier lessons in the course, and they recognize that those are intimately tied to quality reporting and quality improvement. So can you tell us the things that Current Care is doing to support providers here in Rhode Island to achieve those things?
So I think that we are currently providing, actually outside of Current Care, data quality, data management and reporting services for the Chronic Care Sustainability Initiative, which is Rhode Island's patient-centered medical home project. And for that project, we're actually collecting and aggregating data on about 15 quality measures that are sort of related to meaningful use. We're also doing utilization reporting and patient experience through the Patient-Centered Medical Home CAHPS survey, which is what NCQA requires of those practices. And with those data, we're really sort of grouping them up and aggregating them in a variety of ways to help the practices see their performance over time and assess their success with regard to improving the quality and reducing costs, which is, of course, not that easy. But we think that the differences in the data sources associated with what's available to the HIE relative to what's available to a EMR, relative to what's available in a claims data set, all of which are trying to be used for the same purpose of looking at cost and quality, really can potentially result in different answers to the same questions because the populations are a little bit different. So for example, we're working on a chlamydia screening analysis, and I'll be presenting at AMIA in November of this year, in 2014, to look at the differences in those rates between those three population groups. So, a commercial payer will have a different result than a Medicaid payer, which will have a different result than what's coming out of the EMR and the HIE. So we're trying to understand those differences before we sort of report them publicly from the perspective of sort of, here's how you do a better job taking good care of quality docs in the community.
So is it fair to assume that the HIE does serve to help collect and ultimately aggregate the data so that you can do this quality reporting?
I feel like we're really pretty nascent in that regard, and so these chlamydia screening rates are our first entree into it, but I'm pretty sensitive to the idea that we need to understand those differences. Is it that we, as the HIE, have a self-selected population which might have a higher screening rate or a lower screening rate than another group? Are we including the uninsured, which are not really represented in anybody else's measures? So until we sort of dig into that and really are able to benchmark against known metrics, I'm reticent to sort of just say, here's the real answer for the population of Rhode Island. And I think that that's the goal. And I feel confident we're going to get there, but it's one that I think that we need to move cautiously in that regard, because the worst possible thing to do is to report data without really understanding what it means. I think that you can do that in some situations where it's sort of marketing, but quality and cost analytics are not marketing. And when you're presenting information that would reflect how a provider is performing, you need to make sure you have their full engagement and input in how that measure is calculated, and they need to be able to be very, very confident of its accuracy before you report it.
Well, I hope the students remember these comments when we, later on in the course, we get into quality reporting, and I try to show that it sounds great, but it isn't so easy to do.
Yeah, it's really quite challenging, without a doubt.
But it sounds like your long goal is to have a unified statewide population and public health electronic reporting system for the whole state of Rhode Island. Is that where you're headed?
It is absolutely where we're heading, and I believe that I have utmost confidence that we're going to be there. And I feel like we talk internally a lot about where we are today is light years behind where we're going to be in 6 months, and it's light years ahead of where we were 6 months ago. I feel like the progress is really rapid, and I think that's in large part due to a high degree of interest as coming full circle to the beginning of your question, the provider community is becoming more and more interested in these data because they are being held accountable for them. The Accountable Care Organization news releases, the cycle is moving very rapidly. We've just seen in the last 3 weeks 3 or 4 announcements in the news of payer-provider arrangements that are outside of Medicare, so that's pretty interesting.
So one quick final question. We look in the course at some of the public quality metrics that the Indiana Health Information Exchange posts through their Quality Health First initiative. Are you doing that sort of thing here? And what's the reaction from providers to that idea, if you are doing it?
So I think that we have not been so public yet. I think that too is a progression coming back to really needing provider buy-in. And so we're presenting that data to providers on their groups, not at the provider level yet even. And that's a real challenge with regard to N anyway. But we are presenting that to the group of practices that are participating in the patient-centered medical home initiative, where they can actually see their performance relative to their peers in other healthcare settings. But that's what's reported publicly at this point is the aggregate of all of those programs relative to the non-patient-centered medical home data that's available in the state. So it's a process.
Well, thank you very much for taking the time to be with us.
My pleasure.